Today we're gonna talk about obstructive sleep apnea syndrome. Obstructive sleep apnea syndrome is a disorder in which patients experience apneas, which are cessation of breathing, or hypopneas, which are shallow breathing, and is associated with excessive daytime somnolence. Obstructive sleep apnea may be associated with consequences such as motor vehicle accidents. Symptoms associated with obstructive sleep apnea are excessive daytime sleepiness, snoring, nocturnal arousals, apnea, nocturnal gasping, grunting, and choking, nocturia, enuresis, awakening unrefreshed, morning headaches, impaired memory and concentration, irritability and depression, impotence. Pathophysiology. Sleep apnea may be central, obstructive, or a combination of both. In central sleep apnea, absent central drive to breathe results in no respiratory effort and no airflow, despite adequate airway patency. However, most cases of sleep apnea are obstructive sleep apnea and result from decreased or absent respiratory airflow due to narrowing or collapse of the upper airway. Obstructive sleep apnea with symptoms of excessive daytime sleepiness results in obstructive sleep apnea and hypopnea syndrome. Diagnosis. History taking. Lack of recognition and diagnosis of obstructive sleep apnea syndrome is a significant problem. Habitual loud snoring is the most common symptom of obstructive sleep apnea, although not all people who snore have this syndrome. Excessive daytime sleepiness, daytime hypersomnolence, is a classic symptom of obstructive sleep apnea. Patients may describe falling asleep while driving or having difficulty concentrating at work. Patients may also complain of personality changes, intellectual deterioration, morning headaches, automatic behavior, loss of libido, and chronic fatigue. Disorders commonly associated with obstructive sleep apnea include obesity, nasal obstruction, adenoidal or tonsillar hypertrophy, micrognathia, retrognathia, macroglossia, acromegaly, hypothyroidism, vocal cord paralysis, and bulbar involvement from neuromuscular disease. Patients with obstructive sleep apnea often have associated cardiovascular disease, including systemic hypertension and heart failure and stroke. Recent data have demonstrated an increased risk of stroke associated with obstructive sleep apnea. A small study has shown significantly higher glucose and insulin levels in obese obstructive sleep apnea patients when compared to matched controls, suggesting a link between diabetes mellitus and obstructive sleep apnea. Subjective sleepiness can be assessed by a validated scale such as the Epworth Sleepiness Scale. Physical examination. All patients should have a thorough nose and throat examination to detect sources of upper airway obstruction that are surgically correctable. For example, septal deviation, enlarged tonsils, enlarged uvula, especially if continuous positive airway pressure (CPAP) is poorly tolerated. The Mallampati score is used by anesthesiologists to assess the difficulty of intubation. A grade of 1 to 4, 4 being the most severe, is assigned based on the visibility of the tonsils, tonsillar pillars, soft palate, and uvula. Increased severity of obstructive sleep apnea has been associated with increased severity of Mallampati score. Diagnostic testing. The gold standard for the diagnosis of obstructive sleep apnea is overnight polysomnography (PSG) or sleep study, with direct observation by a qualified technician. Sleep studies are typically performed in the outpatient setting. Typical indication for a sleep study include snoring with excessive daytime sleepiness, titration of optimal nasal CPAP therapy, and assessment of objective response to therapeutic interventions. Other indications include unexplained pulmonary hypertension, polycythemia, daytime hypercapnia, and poorly controlled hypertension. PSG stages sleep using electroencephalogram (EEG), electromyography, and electrooculography, and assesses respiratory airflow and effort, oxyhemoglobin saturation, heart electrical activity (ECG), and body position. The sleep study is analyzed for sleep staging and for the frequency of respiratory events, and events are categorized as obstructive or central. Obstructive airflow is absent or reduced despite continuous respiratory efforts. If central, airflow and respiratory effort are absent. The Apnea-Hypopnea Index (AHI) is used to diagnose sleep-disordered breathing and to quantify its severity. All events must have a duration of at least 10 seconds to qualify. Apnea is defined as a complete cessation of airflow. Hypopnea is defined as a more than 30% reduction in baseline airflow that must be associated with a 4% decrease in oxygen saturation. The AHI is the sum of apneic and hypopneic episodes per hour of sleep. The Respiratory Disturbance Index (RDI) may also be reported and can include events that do not qualify for the AHI, such as snore arousals or respiratory effort-related arousals. Obstructive sleep apnea is present when a sleep study shows an AHI of at least 5 events per hour in a symptomatic patient. Mild obstructive sleep apnea has an AHI of 5 to 15. Moderate obstructive sleep apnea has an AHI of 16 to 30. And severe obstructive sleep apnea has an AHI of more than 30. The risk of death, hypertension, and poor neuropsychological functioning rises as the AHI increases. Most sleep studies are performed as split studies, where the first few hours of the study are diagnostic and the later part of the study is used for CPAP titration of the AHI is moderate to severe. Because some patients only have significant events when lying in certain positions, usually supine or during rapid eye movement (REM sleep), these patients may require a complete overnight study for diagnosis and a full second overnight study for initiation of therapy. Differential diagnosis. Patients should be assessed for hypothyroidism, in addition to obstructive sleep apnea and sleep-related hypoventilation. The differential diagnosis for daytime sleepiness includes sleep deprivation, periodic limb movement disorder, necrolepsy, and medication side effects. Treatment. The therapeutic approach to obstructive sleep apnea depends on the severity of the disease, the underlying medical condition, the cardiopulmonary sequelae, and the expected degree of patient compliance. Treatment must be highly individualized, with special attention to correcting potentially reversible exacerbating factors. Behavioral weight reduction for the obese is recommended. Obstructive sleep apnea patients should avoid use of alcohol, tobacco, and sedatives. Medications nasal saline and decongestants help with dryness and congestion. Modafinil may improve daytime sleepiness in patients with persistent symptoms despite adequate CPAP use. Non-operative management. Oxygen supplementation should be used when needed. Positive airway pressure. CPAP is used to deliver air via a nasal or oral mask. Nasal CPAP is the current treatment of choice for most patients with obstructive sleep apnea. Nasal CPAP pneumatically splints open the upper airway and prevents collapse. The sleep study determines the positive pressure required to optimize airflow. The nasal CPAP pressure is gradually increased until obstructive events, snoring, and oxygen desaturations are minimized. Some patients, such as those with COPD, also require supplemental oxygen to maintain adequate oxygen saturations. A saturation of oxygen is 90%. CPAP leads to consolidated sleep and decreased daytime hypersomnolence in almost all patients. Hypertension, nocturia, peripheral edema, polycythemia, and pulmonary hypertension may improve. Auto-titration or smart CPAP machines use flow and pressure transducers to sense airflow patterns and then automatically adjust the CPAP, but their effectiveness has not been well studied. The compliance rate with nasal CPAP is approximately 50%. Compliance can be improved with education, instruction, follow-up, adjustment of the mask for fit and comfort, humidification of the air to decrease dryness, and treatment of nasal or sinus symptoms. Use of a full face mask oronasal has not improved compliance compared to the use of nasal masks. However, full face masks are frequently used in patients requiring higher nasal CPAP pressures due to air leak through the mouth. Bi-level positive airway pressure (BiPAP) can be used to treat patients with obstructive sleep apnea. BiPAP is more expensive than CPAP and does not improve patient compliance. Patients with intolerance of very high levels of CPAP, a poor response to CPAP, or concomitant alveolar hypoventilation may respond well to non-invasive mechanical ventilation with BiPAP or volume ventilation. Oral appliances for mild obstructive sleep apnea, such as mandibular repositioning device, aim to increase airway size to improve airflow. The devices can be fixed or adjustable, and most require customized fitting. Many devices have not been well studied. Contraindications include temporomandibular joint disease, bruxism, full dentures, inability to protrude mandible. Surgical treatment of obstructive sleep apnea. First, tracheostomy. Tracheostomy has been consistently effective in obstructive sleep apnea patients but is rarely used since the advent of positive airway pressure therapy. Tracheostomy should be reserved for patients with life-threatening disease such as cor pulmonale, arrhythmias, or severe hypoxemia, or significant alveolar hypoventilation that cannot be controlled with other measures. Uvulopalatopharyngoplasty (UPPP) is the most common surgical treatment of mild to moderate obstructive sleep apnea in patients who do not respond to medical therapy. UPPP enlarges the airway by removing tissue from the tonsils, tonsillar pillars, uvula, and posterior palate, and it may be complicated by change in voice, nasopharyngeal stenosis, foreign body sensation, and velopharyngeal insufficiency, with associated nasal regurgitation during swallowing and CPAP tolerance problems. The success rate of UPPP for treatment of obstructive sleep apnea is only approximately 50% when defined as a 50% reduction of the AHI, and improvements related to UPPP may diminish over time. Thus, it is considered a second-line treatment for patients with mild to moderate obstructive sleep apnea who cannot successfully use CPAP and who have retropalatal obstruction. In experienced centers, other stage procedures for obstructive sleep apnea can be performed, including genioglossus advancement, hyoid myotomy with suspension, and maxillomandibular advancement. Concomitant conditions such as COPD, hypertension, hypothyroidism should be treated in the standard fashion. Patients with risk factors and symptoms or sequelae of obstructive sleep apnea should be referred to a sleep specialist and sleep laboratory for further evaluation. Complications of obstructive sleep apnea. When obstructive sleep apnea is associated with disorders such as obesity and chronic lung disease, patients may develop hypoxemia, hypercapnia, polycythemia, and cor pulmonale. All non-invasive positive pressure or mechanical ventilation devices may induce dryness of the airway, nasal congestion, rhinorrhea, epistaxis, skin reactions to the mask, nasal bridge abrasions, and aerophagia. Thank you.